This podcast is pre-recorded, intended for educational and informational purposes only, and should not be considered medical advice. Always seek the guidance of a qualified healthcare professional regarding any medical concerns or treatment decisions.
Hi, everyone, and welcome. Today, I'm very, very lucky to have a great friend and colleague of mine, Jennifer Tao. She's based in, I think, the New York region in America. Is that correct? My geography is very
Connecticut.
bad.
Nope, you're good.
Connecticut. Okay.
Connecticut.
So today, the topic of our chat today is going to be infant feeding, lactation support, and in essence, like all of the episodes we've had, is how to make the best team around us. And what I find when treating infants and older babies, that it's always vital to have someone who's aware about lactation, whether they be an IBCLC, whether they be someone as experienced as Jennifer, who's been doing this for now about 30 years. Wow. Probably just nearly as long as I've been alive at this point. So to start off with, I'll just get Jennifer just to tell us a bit about herself, what brought her into, what got you started on kind of doing the work you do.
Well, I'm super happy to be here with you as well, because you have been such a great co-team player for me with the families we've shared together. It's been a really great experience, and that makes everything work. So for me, I never thought I would be in this field, to be honest with you. My undergraduate degree is in art, and I was working as a photographer, art director, designer for 10 years before I ever even considered doing anything with breastfeeding. But when I had my first before I had my first baby, I kind of segued into the world of holistic care. I was
Mhm.
diagnosed with endometriosis. I was told I couldn't have children, that it was severe. I would need to do surgery. I would need to do drugs.
Wow.
The universe just has its own way. And the day I was diagnosed, I had no surgical procedure except the diagnosis. I discovered there was something in the world called homeopathy. Who knew? And so I called a homeopath and made an appointment, really just trusting intuition, nothing else.
Mhm.
The person I made the appointment with was a medical doctor who had transitioned to homeopathy. And I was on Darvocet every month. It's a pain reliever because I was in so much pain for 3 years. And I never took a drug again after I met him the first time. Within 6 months, I was completely symptom free. I conceived my first child in a month. So I never had difficulty conceiving children, and so it completely changed my worldview. It changed my understanding of our physiology and how we interface with the world. But then I still was working as an art director. I really loved the work.
Mhm.
But I did become a La Leche League leader, and that was my gateway. La Leche League is volunteer, so I was volunteering at a local WIC, which is Women's, Infants, and Children's in the United States. It's a supplementary feeding program for low-income families. And I was volunteering there, and we were having these luncheons every month that were really popular, like 30 moms coming to these
Mhm.
luncheons to learn about breastfeeding. And by 6 weeks, they were all weaned. And I just thought, I'm
Wow.
a part of the problem. I'm not solving anything. I can sit here and
Mhm.
sing the praises of breastfeeding, but if I'm not helping these people, what am I doing? So I wrote a grant, and I got a 3-year grant for a breastfeeding peer counseling program at an inner city hospital. And I wrote the whole program, directed the whole program, trained the 40 peer counselors, and it just kind of shifted me more and more
Mhm.
towards breastfeeding. Um, and I kind of left behind working as a designer because now I had 2 children. My daughter was born
Mhm.
at that time as well. And I just thought the world is going to be a better place for them if I do this work than if I design another great logo. So that was kind of my segue into breastfeeding. After I left, the last year I was at the hospital, I wasn't going to become an IBCLC. I thought breastfeeding belongs to us as human
Mhm.
beings. Like, why do we need to pay people to breastfeed? But one of my peer counselors, who later became a naturopath, said assisted birth will require assisted breastfeeding. And she was right. We've changed
Mhm.
the trajectory of how we experience our own bodies, and we don't have the trust, the innate trust in ourselves and our babies that we're really designed to have. And so all of this birth intervention, which I saw firsthand in the hospital, my own babies were born at home, so it was quite a shock for me, actually. All
Mhm.
this birth intervention, which is so harmful to breastfeeding, really leads often too a need for support with breastfeeding. And so I thought, well, if I'm going to leave this environment and I want to help families, this is kind of the direction to take. It was either become a midwife or become an IBCLC. And I have the most respect for midwives of all professions, but I didn't want to
Hmm.
leave my babies in the night to do that. So I took my exam in 1996 and became,
Wow.
I know, and became an IBCLC shortly before I had my third baby, and I went into private practice. And in 2010, I took my practice completely global because I moved to France. And so my practice has been global since 2010. So that's really kind of my progression into lactation. And then we can talk about how I became involved with posterior tongue tie when you're ready to talk about that.
Oh, look, great. No, it's such a beautiful story. And especially I love the fact that you said like intuition and universe, because I'm a big believer in divine guidance. Actually, today I was listening to a podcast and he was talking about how the whatever you want to call them, God, universe, divine power, always kind of gives us clues to get us where we need to be. And you just need to be receptive to hear it. So, what kind of originally drew you to working with breastfeeding families? That's the what I want. What kind of? I know we talked about how you're very holistic. I know we talked about how you're very holistic, but what drew you to working with breastfeeding families?
I think that what I came to understand through my own experience of healing with working
Mm.
with the homeopath who I worked with, and from there on, like really avoiding allopathic medicine as a first or second or even third line. It sort of it has its purpose for sure, but it I realized that it's not a healing modality. It's about sure it rescues us in emergencies, right? I mean, I broke my
Mhm.
wrist. I needed to have it set, those kinds of things. But it doesn't help us to understand and know ourselves. Breastfeeding, from my experience as a mother, people say, I wish babies came with an instruction book. Breastfeeding is that instruction book. It really is
Mhm.
your guide. It really is your guide to your baby if you're responsive to your baby and into parenting. And so I found that if I could support breastfeeding, then I could support something really fundamental in helping families really feel confident in the way they raise their children. For me, I felt really confident as a mother. And I find that a
Mhm.
lot of mothers in our world today don't feel confident. And I think that lack of confidence is largely fed by social media. Do it this way. No, do it this way. That's wrong. No, that's wrong. That's right. I mean, it's crazy. Moms are so challenged with what is the thing to do,
Mhm.
right? But the answer really is still in here. It really is still in here. And I feel like when we breastfeed, we tap into that. So I really felt like the most beneficial route I could take in my life, in my work, was to support the families who wanted to breastfeed their babies. That's what it felt like to me. And so far, I haven't gotten that nudge in another direction yet. So if I do, I'll let you know. But so far, that has felt like that just felt like the right path. But I will say this too. I do find that the families who are most drawn towards kind of seeing it in a more holistic view tend to find their way to me, which is really helpful to me as well because we start on a more common ground. And I find that I can be most helpful to those families, families for whom
Mhm.
breastfeeding is really about parenting as opposed to simply about a way of feeding their babies. Not that I'm unwilling to help any person at all who wants to feed their babies in a healthy way, whether that is combination or breastfeeding. And I've helped families who exclusively formula feed for reasons that make sense to them because they still want to do that in the most responsive way possible. So all of that matters to me, right? So what I always say is that I want a family to leave more confident than when they entered the space with me. That is what's important to
Mm.
me because that is the grounding that keeps us from being pulled in every direction by all of the influencers out there who have a 6 month old and are an expert on all things parenting, or who have, never breastfed, but yet somehow see that as a place to, monetize or whatever it is. It's just really challenging for families. And so my hope is that that groundedness and that confidence allows them to kind of navigate their way in a way that works for them and their children.
So that was a very, very good explanation there because let's put this back. When a few years ago, before I delved into the whole world of tongue ties, etc., if someone asked me about breastfeeding, I'd be like, "Oh, that's just easy. You just put the baby on the breast." But the more and more I've kind of delved in, I was like, Suraj, how wrong you were. Now, do you feel that as times have evolved, and like I remember once we had a conversation some time ago that in the UK we have one of the lowest breastfeeding rates in the world. What kind of patterns do you think, or what misunderstandings do you think people have about breastfeeding?
Yeah, that's a really good question. So I think that we need to understand where this came from, right? So
Hmm.
really in like the 16, 1700s in Europe and very largely in the UK, by the way, male experts, self-appointed experts, started to tell mothers how to feed their babies. And what they did is they made a lot of rules. Only feed every so many hours. But in particular, what they did was they made rules about how you interacted with a baby, right?
Mm.
So you were meant to not be responsive. You didn't want to spoil babies. There were people who were told not to touch their babies any more than was necessary, not to hold them, not to cuddle them, not to sleep with them. And, people today might think that's extreme and crazy, but the truth is that is still the foundation of the beliefs we have about child rearing in the West. And really,
Mm.
throughout all of Europe, throughout the United States, through Canada, that is our foundation. So even though we may, of course, snuggle and love our babies and hold them and
Hmm.
inhale them, the truth is we still have this idea, this cultural idea that you can spoil a baby, or that babies can learn to self-soothe, or that babies have to get themselves to sleep. All kinds of things that are really in conflict with our human physiology and our human design. And I think sometimes when people understand the origins of their beliefs, they can start to unravel them and recognize that maybe that's not really my belief. Maybe I just accepted that for such a long time without looking into it. So we really need to understand that there's a cultural underpinning towards breastfeeding
Mm.
that really comes from this idea that parenting should be something distant and remote and authoritarian. That is not the way the rest of the world raises their children at all. And so I think that the expectations that we have on babies, aside from the expectations we have on mothers who should carry the burden of all things and always be
Yeah.
guilty and wrong in all things, right? But the expectation we have on babies is so unreasonable. You have an amazing person in your country, Helen Ball, who's written a beautiful book on infant
Mm.
sleep. And we have James McKenna here, who is our infant sleep expert. And the strangest thing, these people know infant sleep so well and understand the physiology so well, and yet they are not the experts that who are turned to understand
Mm.
what recommendations should be made. The recommendations are in constant conflict with human physiology. So I think that so much of our struggle comes from the fact that breastfeeding, and I'm going to say this word, is physiologically easy, but culturally it is extremely difficult. So you take something that's meant to, it
Mm.
has to be meant to be easy because it's
Yeah.
meant for all mammals to do it without fail or with very little fail, lest our young does not survive. And yet, culturally, we have made it so incredibly difficult by all of these external rules and regulations and ways of being that are in conflict with breastfeeding. And in the United States, and I know it's true in Australia, the UK, sleep training has become a big thing. And that
Mm.
that has really overpowered breastfeeding success for so many because babies need to eat 24/7 for the first year of life. They have to. That's their normal physiology. That is what drives their metabolic wiring. That is how they become healthy adults. And so when you overfeed during the day so that you can avoid feeding at night, we are creating a metabolic disaster. And yet parents are not
Wow.
taught that. I do want to say this because I work with mothers, right? Mothers are my clients,
Hmm.
not really the babies in a sense. We live in a culture that is dealing with food toxicity to an nth degree, right? Our food is so
Hmm.
toxic. Our environment is so toxic. Our water, our air, microplastics are everywhere. Microplastics are in placentas, right? So we're dealing with all of that all the time. So what I think has happened is that we have moms going into pregnancy really depleted, nutritionally depleted, and so sleep feels like the only way to survive, to get enough sleep.
Mm.
But what I find is if we remineralize people, if we nourish people, they are able to manage the normal sleep patterns of infants. They're challenged to manage it when they're nutritionally starved. And when they have airway issues, right? When they have airway issues.
Yeah.
So in my intake form with my clients, I always assess their airways as well. Meaning I just do a sort of a screening of their sleep, their airway, their dental stuff too, because I know that that's going to influence how they feel like they can handle their days and their nights with their babies. I think I segued
That's
into another place there, but
no, it was really good because we got to hear about like another thing that I kind of think as well. When you talk about the 1800s, our diets, I think, were very different back then and they're very different now. And like you mentioned very clearly about microplastics, about the available pesticides, etc. And we kind of, as a generally speaking, we brush it off. We're like, oh, this is not going to affect us. But actually, if we look at ourselves from a microscopical level or a cellular level, we're going to see that our cells are actually not functioning as well as those old humans. And it's very sad to see that we're going to be the first generation that's probably not going to live longer than the generation before us due to all the
exactly.
effects of industrialization. So I've heard that a lot, and it's something that it's always at the back of my mind because when we look at, for example, the mother-baby dyad, there's always times that I kind of see crossover of, let's say, for inflammation. So what I want to just ask a bit about on this side is what exactly, so for everyone out there, does breast milk contain? What are the health benefits? And also, I'm going to give you a bit of a tricky one here. Is it possible that, for example, mother's inflammation can be passed on or intolerances can be passed on in the breast milk?
Actually, that's not tricky. That's actually my area of expertise. So thank you for that.
Okay.
Um, so, so I say that breastfeeding is downstream of metabolic function, right? And it's
Okay.
downstream of cellular health, of cellular
Hmm.
integrity, right? So, for example, I just did a talk yesterday on the fat-soluble vitamins and breastfeeding and the critical importance of vitamin A, for example, to thyroid function and iodine. Let's use iodine as an example. When a mother has borderline hypothyroidism, and she gives
Hmm.
birth, the need for iodine increases dramatically for the baby. So now we have the breast and the thyroid competing for a limited amount of iodine if the mother is iodine deficient. So yes, inflammation is substantially key to what's happening with breastfeeding. So you'll still see people saying that they'll throw some crazy number out. None of this has any basis in science, but 1%, 2%, 3% of mothers can't breastfeed and everybody else can, right? Well, if you think about putting your baby to breast, even if you don't have a full milk supply, sure. You just said that what are the advantages of breastfeeding? One of the things we used to talk about all the time is that you can't have an advantage to a physiologic norm. That's like asking what
Hmm.
is the advantage to breathing, right? So there isn't an advantage to a physiologic norm. You give
Yeah.
birth and your body will prime to breastfeed. It's not a choice to breastfeed. It's only a choice not to breastfeed.
Hmm.
You can stop breastfeeding, but realistically, for the 99.999% of women, in some way breastfeeding will begin. Doesn't mean they will have a full milk supply, but the body will begin to do that, right? To make that process happen. So there's not an advantage to that. There's only a disadvantage to not breastfeeding. So breastfeeding, I don't think there's any person out there who would not say that breast milk is sort of nature has designed breast milk to be the perfect, combination of macro and micronutrients for the human infant. I don't think anybody's going to argue that. But it's so much more important than that because it's a tutor, it's a primer. Breast milk is the tutor to the infant's immune system. One of the reasons we don't introduce solid foods early is because the infant's terrain is being developed towards a functional immune system, not towards digestion of food. Breast milk is easy to digest for a very good reason. Now, of course, it creates the problem of it digests in an hour and a half and the baby wants to nurse again, right? But the
Hmm.
benefit to that is that the baby's body, the terrain, the microbiome doesn't need to spend a lot of time on digestion like ours does. It's spending its time on tutoring the immune system. And in every single dose of breast milk, which is why, even if you can't exclusively breastfeed, every dose is valuable. With every
Hmm.
dose of breast milk, that tutor is being primed and activated. So the baby's immune system is being taught this is self and this is other. This is what you respond to. This is what you don't respond to. You don't react to foods. You don't react to birch pollen or whatever it is. You react to this pathogen. So that's what we're teaching in those first 6 months. The minute you introduce foods, the microbiome
Hmm.
now has to change, and we have to then multiply the strains of bacteria that would digest food. We don't want to do that early. We don't want to preempt the development of the immune system. We want that to be fully established before we ask the baby to digest other foods. As soon as you introduce formula, you have introduced another food. You have changed that direction, right? Now we
Hmm.
can recover it if we introduce if formula is given as necessary early on, we can recover it by exclusive breastfeeding afterwards. But the point is that exclusivity of breastfeeding has a purpose in the development of the infant immune system. And what you'll see, because we have a tendency to only think about our own experiences or our very close circle of people. People will say, I was formula fed and I'm fine. My kids were formula fed, they're fine, whatever it might be. We're not fine as a culture. There's no way we're fine. We
Mm.
are not healthy. We are the most unhealthy population ever. So the argument in some way that there's an equivalency between being breastfed and formula fed, it's just not true. It can't be true, right? There cannot be a best and a best. That can't happen, right? So what's in breast milk isn't just about the components of breast milk. It's about the education that breast milk provides
Yeah.
to the infant. It's about the protection. It's about the secretory IgA, the Hamlet cells. There are so many components of breast milk that have nothing to do with just food, right? So if you think about it, they're a wiring mechanism. That's what they really are. They're the soft breast milk is the software. The baby is the hardware, right? So we want the
Hmm.
software that's attuned to that hardware, right? And that's what breastfeeding is. So we need to understand that what's in breast milk, the design, right, of what's in breast milk is really a perfect match. However, what isn't in the mother's body can't be in the breast milk. If a mother is deficient in iodine, which is a huge problem in the West, if a mother is deficient in vitamin A, another huge problem in the West, if a mother is deficient in B vitamins, another huge problem in the West, the sufficient quantities of those nutrients will not be in breast milk. They can't come from nowhere, right? And even if we draw some of those out of the mother's stores or the mother's body to the degree that we might be able to, now we're making the mother deficient, right? And that's not
Hmm.
what we want to do either. So a lot of people believe that breastfeeding makes mothers weakened or deficient. That's not true. Mothers who begin weakened or deficient because of poor nutrient status, and that could be as a result of I know you're in the UK, but a standard American diet, which we've exported everywhere because we're good at
Hmm.
exporting bad ideas. So, a standard American diet or use of birth control pills, which depletes the body of all the minerals and nutrients that we need to grow a baby. And many women
Hmm.
go off the pill and get pregnant without ever repleting their nutrients, right? Or having babies spaced closely together. The human design, like every mammalian species, we have a normal design, right? Our child
Hmm.
spacing is meant to be somewhere between 3 to 5 years and closer to the 5 years. We tend to space our children very close together, which doesn't give us the opportunity to replete nutrients before the next baby, right? So there are a lot of
Hmm.
things that happen, and people might have very good reasons for doing those things, but we do them without the education that around nutrient, repletion. So we now have a highly inflamed population, right? Americans, people in the UK, much of Europe, although I think we take the cake over here, I'll be honest with you, in terms of inflammation. I mean, we have almost 50% of our children now have some kind of chronic inflammatory disease, right? I mean, it's crazy.
Wow.
It's insane. And so when I started doing this work, it was a very rare thing that a mother going into having a baby in their 20s, 30s, or 40s would have diabetes, unless it was type 1
Hmm.
diabetes, would have diabetes, would have thyroid conditions, would have, years of taking anti-inflammatory medications for various reasons. Now it's rare to see someone who doesn't. That's a huge flip, right? And so mothers are going into pregnancy at a deficit in terms of what they have available for their babies. And pregnancy and birth are highly inflammatory processes to begin with, right? And so we're not mitigating that inflammatory process. One of the things I talked about yesterday in my lecture is vitamin E. Vitamin E is critical as an antioxidant to prevent to prevent reactive oxygen species that are produced from PUFAs, right? Which include
Hmm.
DHA. Well, everyone takes DHA when they're pregnant, but they don't take vitamin E. So they're actually amping up their inflammation because they're not being told that you need to actually take this antioxidant as a means of reducing the problem. Or people are told, oh, don't take folic acid in your vitamin, your prenatal vitamin, take folate. Okay, except the food supply is full of folic acid. So if you're eating grains that are all fortified with folic acid, you're
Hmm.
really not solving the problem, right? So how we eat and how we move. I did a whole lecture on movement and how lack of movement in pregnancy, in my mind, is one of the reasons we're seeing so many tongue ties because we're creating
Okay.
a fascial system that is so tight and restrained and restricted because of lack of movement. So and these are not intentional things that mothers are doing, right? And the problem becomes, well, then you're blaming people. But my argument is, no, we're educating people because you can't change something you're not aware of. If you don't know
Exactly.
how important it is to say, have your nutritional status tested, for example. I like my clients to get labs run. Let's see what your vitamin A looks like. Let's see what your zinc looks like, right? And so if people knew that there were things that they could do differently, I'd like to think that they would do them differently if they had that information. So I always say that information doesn't judge. It can't. Data can't judge. Facts can't judge. It's how you apply those facts. And what I find is we gatekeep the facts. We don't, we treat
Hmm.
women as if in some way they're too fragile to handle information. And I don't believe that. I think that anyone is capable of handling information, and it's not our job to decide which people can handle it and which people can't. It's our job to offer it and let people utilize it to their, hopefully to their advantage, right? So I think that
Hmm.
if women prepared for pregnancy in a very different way and really optimized their nutrition and their airways before going into pregnancy, then I think that we'd have a very different outcome in terms of breastfeeding because I don't think breastfeeding would feel so challenging to people who felt more nutritionally balanced and stable.
That's very, very good advice. So I'm just imagining is someone who's looking to get pregnant, etc., someone who is pregnant, your advice for them would be definitely get some bloods done, make sure you can check their vitamins, minerals at that point to kind of see where they're deficient. And obviously, this is not medical advice by any way, but look at proactively supplementing on that side. Um, is there anything else you would say to the mothers who are before they give birth, anything they can also work on? So you said movement's great as well. We talked about the airway breath work. Is there anything else before we actually start looking at the baby once they're born?
Well, I mean, sure. I think that the problem is that if you're going to work with mainstream practitioners, they're not
Mhm.
going to do any of the things I just talked about. They're going to
Yeah.
run very basic labs. They're not going to look at the nutritional profiles that I'm asking for. So you would want to work with somebody, a nutritionist, a naturopath, somebody who has that knowledge base, right? So that's important. But you can do a lot of things with food and with herbs that are good for pregnancy, like oat straw, like nettles. Like there are lots of herbal infusions that you can take during pregnancy that are full of minerals. One of the
Mhm.
things I tell my clients is just make a homemade mineral broth and drink it every day. That alone will boost your nutrition so well, and it's cheap. You're literally taking the leftovers of your carrots and your onions and your garlic and your whatever, right? And throw in your
Yeah.
turmeric and your herbs that are safe and healthy in pregnancy and throw in your greens and make a broth and just drink it every day. Use it with anything that draws up water. If you're going to make rice, if you're going to make quinoa, use that as your foundation. If you're going to make soup, that alone, right there,
Mhm.
is going to mineralize and increase your flavonoids, increase your antioxidants. There's so many simple things that people can do. It doesn't have to be super expensive, right? So
Mhm.
just being attentive to thinking about nourishing yourself on a daily basis. And movement isn't a nice thing. Movement is a necessary thing, though. And I don't mean that people have to go and do a workout. I mean, the movement that we have historically done has been in the course of our day as we garden, as we, go for walks, if you think historically, of course, if we
Mhm.
carried the water 2 miles from the lake or whatever, but the point is that if we think in that sense of that kind of movement, that's the kind of movement we're missing, right? So those are the things that I would say that people can do during their pregnancies. But I would really strongly encourage people as much as they can to consider getting together with somebody who actually does have the capacity to make a good evaluation of their nutritional profile and it really help them to be better nourished going into pregnancy and delivery.
Lovely, lovely. Great advice there. Now, if we have so this is probably where we both collaborate at this point. So one thing I always get in the UK is mothers who struggle to breastfeed. The kind of system here, unfortunately, is always putting the blame on the mother. It must be your fault.
Right.
There's something wrong with your supply. And sometimes these mothers, assessed by another lactation consultant, have great supply. The milk's good, but this child's not gaining weight, and that unfortunately the blame's put on them. Now, we know that tongue ties obviously play a factor, which we're going to discuss afterwards. But what would you say, coming from your side as a breastfeeding consultant, would be the first like red flags that you would see where breastfeeding is not functioning well?
Excuse me. I always
Bless
look
you.
for I always I always look for compensations. That's what I look for.
Hmm.
So one of the things that mothers are amazing at, and you're right, mothers get blamed everywhere. It's always the mother, right? Frequently, it is not the mother. It is a baby issue or it's a combination issue, right? Because mothers and babies are a unit. They're an ecosystem. We can't separate one from the other. But mothers are phenomenal at responding to their babies. So frequently they are compensating in ways they haven't even thought about. You see the mother who, for example, nurses her baby in a cradle position on the left side and switches to a football position on the right side and doesn't even think there's like, oh, the baby nurse is better if I do that. That's a compensation. You shouldn't have to do that. That tells me that there's a structural problem, but that mother
Hmm.
is so intuitive that she has found a solution, right? But it is a compensation. So that's what I'm always looking for. What are the compensations? Another example would be because we're such a pumping culture as well, mothers think they have to pump to breastfeed. Many mothers are shoring up their milk supply by pumping or using something like a Haka, which they think isn't a pump. If you're removing milk, it's a pump. So many mothers are shoring up their supplies without realizing it, right? But the baby would never be able to drive that supply on their own.
Hmm.
So that's one of the things I'm looking for. Is that baby competent to drive a milk supply? It's okay if you choose not to fully breastfeed, but your baby should be able to, right? We want a
Hmm.
competent baby. So if the baby is able to do it, that's what I'm looking for, not what you've decided to do. But if you're doing this as a compensatory process or you don't even realize it's a compensation, that's a problem. So that's what I'm looking for. I'm looking at the baby structurally, right? Those banana babies, those babies who can only turn to one side,
Hmm.
those babies are going to necessarily compensate because I remind parents that we don't eat with our heads turned. We eat in midline, right? Babies can't do it either. So if a baby has to be in this wonky position to feed, that's a problem, right? So I'm looking for those kinds of problems. So when I'm watching a baby feed, obviously I'm looking for things like this is a really common thing when a tongue tie exists or any kind of oral dysfunction exists, babies have a tendency to pull back into a shallow latch, and moms will say I latch them on deeply and they keep pulling shallow. I latch them deeply, they keep pulling shallow.
Hmm.
Babies do what they are capable of doing. If your baby is pulling shallow, it's because they cannot feed in a deep latch. So why not? Right? Is it that we just need to change the mom's positioning of the baby? And sometimes if we just lower the baby down so the baby can extend a little bit, we're good to go. But often that's not the problem. Often the baby has a structural problem that it's more comfortable for them to be in that retracted position. And I remind parents if your baby's in a battle between breathing and eating, breathing is going to win, right? So
Exactly.
that baby who's retracted, that baby whose jaw is pulled back because of a tongue tie or another structural problem. It could be a difference. It could be, because of the baby's positioning in utero. It could be because of birth trauma. But if the baby can't get out of that position, then the baby is not going to be able to have a deep latch, period. So that's what I'm looking for. What is the baby able to do? And what is the parent or the baby or in combination done to compensate for what the baby cannot do? That's why I say that people have taken the term functional feeding, which I'm going to say I'm pretty sure I'm the
Hmm.
person who coined that term. People have taken that term and misunderstood it. So now they talk about functional assessments, but a functional assessment is a feeding assessment. It is not a finger in a mouth seeing how a baby sucks on a finger. That's not a functional assessment.
Hmm.
That's not how a baby functions. Right. So it's not like we don't check that necessarily, although 90% of my clients are remote, so I don't. But when a mother says, my baby has a strong suck, big red flag because babies shouldn't have strong sucks. That's a compensation for a dysfunctional suckle, right? When a
Hmm.
baby uses their lips to hold on, that's a compensation for a tongue that can't hold on, right? So those are the things I'm looking for. How is the baby compensating for what they aren't able to do, right? And then the first thing I look for is, can we correct that just by changing something the mom can do, right? And if we
Hmm.
can't change it, correct it that way, maybe we can make it better. But if we can't get to full function, then what's the next step? What do we need to do next? Do we need to implement some oral exercises? Do we need to refer for body work? I always do an oral assessment on every single baby. And I will admit, I
Hmm.
don't care who the other lactation consultants were before, I still do it. I still want to see for myself what the baby looks like orally. And also because I want to see how they're moving those muscles, right? How are they responding to somebody lifting their tongue, moving things around? So, but those are the things I look for. I always look for compensations first and foremost. And not only what I see, but in the way the parents describe things. I take a narrative history. I don't have
Hmm.
my take form is demographics and hi, why are you here? But I don't have a long intake form. Number one, because I don't fill out intake forms. I put the least amount of information I can ever put, and I leave things out all the time because I think you don't need to know
Yeah.
that. So I do it as a narrative so that people can tell me their stories because I want to
Hmm.
understand how the mother got to where she is now. What's your story and how did you get here? Because I want us to land in the same place together. And I think that a conversation does that better than a tick box. So the combination of the story and the assessment is how I determine what's going on with feeding.
That's very, very clearly and well put,
Mhm.
Jennifer. I really like it that way because you've given quite a good structure. And I agree with you a lot of times. Sometimes, if I'm getting a patient as well, a lot of times I get that, oh, wait, they've only got a lip tie because they checked the tongue tie, it's not there. And funny story, actually, in Christmas, I was with some friends in Spain, and she just recently given birth. The baby was about 2 months old, but she was saying it was so painful to breastfeed. He had destroyed her nipples, but there's no tongue tie. And I'm saying to myself, this is definitely a compensation because she's like, well, he's he's just very, and he's exactly what you described to me, banana baby, really tight. I saw him sleeping, hands are clenched like he's about to
Mm.
box. And the one thing she said to me, which I was going to dispel the facts with you, is pain during breastfeeding is normal. Now, as far as I'm aware, it shouldn't be normal, but how would you say if the, like, from what I've heard, is it should be uncomfortable but not painful? But I'm going to let you just answer that question. Pain during breastfeeding, normal, abnormal, slightly common?
So, well, common isn't normal. We know that, right?
Yeah.
So, sure, it's common. Is it normal? No. And the thing is, we tend to normalize our own experiences, right? So the mother who toughed it out for 6 weeks or 8 weeks and then it got better, what I tell that mother is that what you did without realizing it are all these little micro compensations. The two of you figured things out together. So maybe that baby was latched on to the nipple, grasping with their jaw, and over time, you managed to get them a deeper latch. You managed to use a different position, whatever it was. And so you think that your nipples somehow recovered or
Mhm.
became numb or whatever. Let's hope your nipples never became numb. But people have these weird ideas where they think their nipples have to toughen. That is not the kind of tissue we want to toughen. That's not going to happen, right? So there's a lot of people. People always need to explain their own life experiences. We all do. It's totally normal.
Mhm.
But people will often give you explanations that are incorrect. Like their experience is real, but their rationalization or understanding of their experience is limited to what they think is true. So many parents will believe that they had sore nipples, they went on to breastfeed, therefore it's normal, right? So I remind people that when the sun comes up every morning and you get
Mhm.
up every morning, does not mean that you got the sun up. That's not how it works, right? So those relationships don't quite work that way. So if we think about it, physiologically, nature's design would never be for it to be painful for us to feed our babies. And especially as social mammals, how would that make sense? Because so much of breastfeeding is about the relationship. And pain does not engender a good relationship, right? It doesn't make sense. If you're afraid to put your baby to breast because it's going to hurt, how is that impeding that bonding relationship? That is not nature's design. That makes literally no sense. So there's no rational way that we can explain that pain would ever make sense, right? So no, uncomfortable, Sure, it can be somewhat uncomfortable,
Hmm.
especially the first time you ever nurse a baby, because who's ever felt
Hmm.
that before, right? We've never felt that before.
Yeah.
So it can be a little bit tender, especially as you're figuring out what a latch should be like and where the baby should latch and a good position and all those things. Sure. But should it be painful? No. I use this little analogy when I teach families about this, that in our culture, I'm sure this is true for you, when your kid gets to the age where they can drive, whatever age that is in your area here at 16,
Hmm.
they get behind the seat of the car and they're like, they know how to fix the mirrors. They know what all the everything means. They know what everything means. They know how to,
Hmm.
they're going to set the radio to their station. They know the brake. They know the clutch. They know how to change gears. They know all the things because they have been in a car for 16 years, right? They've watched you. They have no question that they're going to pass their driving test. Sure, they might be nervous, but they're going to drive. They're going to know how to drive because people drive, right?
Hmm.
But if you took somebody from 100 years ago or 200 years ago who's only ever driven, a horse and buggy, and you sit them behind the wheel of a car, they don't know what to do. That's us with breastfeeding today. We're the kid with the horse and buggy because we have not
Hmm.
grown up seeing breastfeeding. So we don't know what it looks like. And when we start, we don't have that sense already that of course I can do this. Everybody I know has ever done this, I can do this. That's not where we are. We're at that place where we're like, which is the brake? How do I start this thing? That's where we are. And so we're at such a deficit in terms of breastfeeding. That's where we're beginning.
I do see that a lot because I think obviously being in the UK, we all discussed about the amount of support available for mothers. I think the system tries to get them to breastfeed, but in the end, most mothers are just given a bottle and told this is the best way forward. And that obviously brings into the whole, that's why most of the patients come and see me because they were like, something's up there. Intuition's been bugging them. They're like, a bottle's not going to fix this issue. There's something wrong with my child, and no one listens to them. And I see that coming more and more as a society as well. Now, on that topic, obviously, this is a very, very controversial question I'm going to ask you, and I don't think there's no right or wrong answer. I tell all my parents, as long as it's a personal choice, this part, but a lot of them ask me, how long should I be breastfeeding for? Now, WHO guideline says about 2 years. I myself say that is equally your decision. And I was going to ask from your point of view, we all know the added benefits of the breastfeeding, like we said, from a dental point of view, helps develop the palate, the jaws, from a mother-child point of view. But when would you say is, in your ideal world, mother should, if a mother came to ask you, should I stop breastfeeding? When would you say is the right time?
So you already answered the question yourself, which is that there isn't a right time, right? I mean, you're right. There is not a right time. I think the bigger question is not, is there a right time, but where did we ever get the idea that babies breastfeed for a year? Where did that come from,
Mhm.
right? So again, if we challenge the underlying beliefs or the underlying presumptions, really, we often recognize that they came from a place that makes no sense. So babies who are formula fed need to be fed formula for a year. So that's our presumption of how a baby gets fed is that year of formula feeding. So it has
Mhm.
nothing to do with breastfeeding. Babies don't suddenly turn one and they're a different person than they were the day before they turned one, right? So again, we have a design. All mammals have a design, right? And so there's a sort of a duration of normal feeding, physiologically normal feeding for all mammals. And for humans, it's years, it's not months.
Mhm.
And I often see people say, I don't understand why my child has, poor oral development. I nursed them for a year. A year is not the normal duration of breastfeeding, actually. It's years. And
Mhm.
I'm not saying nursing for a year in our culture is not a big accomplishment. It is. It really is. But what I'm
Mhm.
saying is that from a physiologic perspective, in terms of guiding growth and development, you kind of left the tracks before the train got to the end of the station, right? So the other thing is that many times that year of breastfeeding or even longer is dysfunctional breastfeeding because those kids have tongue ties or other structural problems
Mhm.
that were never addressed. My daughter nursed for years with a tongue tie. I did not know then that she was tied. She's 33 years old. I didn't know then that she was tied. I did not know until she was 13. And at that point, I still didn't have enough knowledge. I was not yet a myofunctional therapist, which I have been now since
Mhm.
2013. I did not know then what the impact was for an older person, right, that she was tied. So it wasn't until she was 19 that we had her tongue tie released. So
Wow.
I think that we've got a cultural idea that a baby has to be fed something for the first year. They have to get formula or breastfeeding, right? But then because we have that year mark in our heads, we imagine that breastfeeding is a year-long thing. I guess that's what I would argue is that if we take that away, then it's just however long you breastfeed, right? And for some parents, that changes because they get pregnant and their baby decides, I don't like the taste of this anymore, I'm done, which happens a
Hmm.
lot, to be honest. I tell parents that older children are more likely to nurse through pregnancy than younger children because as they're older, the relationship is more profoundly important to them than the baby who's just like, can I please have my milk? So, it really depends on so many variables. So I would never presume to tell a person how long they should breastfeed. I'm more likely to say to a person, if you're feeling a cultural idea that says you should stop when you don't want to, let's talk about that.
Hmm.
I will support you in continuing to breastfeed. If you're saying to me, I'm done for whatever reasons, and they're not coming from someone else, they're really your own reasons, and you need some help with doing that, then I will help you to do that. Right? So I just want it to come from that dyad, not some external pressure on them from other people telling them what they're doing is wrong. Right? That's my biggest concern. So, in terms of the physiologic reasons to breastfeed, there's so much value in nursing well beyond that first year and even well beyond 2 years.
Thank you. Yes, no, it's a very controversial topic, and I just wanted to get your view on it because it's someone was saying like I felt very bad for this person because they were talking about their experience. They said beyond 6 months it became too painful for them. They had to stop, and they were shamed by other parents. And I said, this is where the culture needs to understand that it's everyone's individual choice of when to start, when to stop at that point. Obviously, you're there to guide them, we're here to guide them, but it's a very personal thing.
But what
Now,
I would
well,
say, can I
yeah.
can I just say this? If pain is the reason you're stopping, that means that there's something wrong. Like I would hope that for the most part, people are able to make the choice from a place of just a
Mm.
choice versus because that's an external imposition as well, if you think about it, right? Because pain
Yes.
shouldn't be happening. So I had a client once who nursed her first three babies for over a year in terrible pain with every single child. I didn't meet her until the next child. And the next child is the first one that we then knew we
Mhm.
identified as tongue-tied. And I will never forget her having the release with Betty Carrillis. And she was coming back on the ferry from New York to Connecticut, and she cried and she said, "This is the first time I ever felt a baby breastfeed. The only thing she'd ever felt
Wow.
before that was pain." Right? So that
Wow.
wasn't a choice that she was making to
Mhm.
stop nursing at a year. It was pain that drove her to stop. Whereas this child, she went on to nurse much longer because nursing was now pleasurable for her and that
Mhm.
baby. So I guess what I'm saying is that no, no one should ever get into someone else's face about why they make a choice they're making. But what I'm saying is I would hope that most people have the ability to make a choice and aren't being driven to something out of pain or pressure from other people.
No, precisely. Well said on that side. And I think we need to, this is the message we should be spreading a lot more because it's very easy for people to pass comments on that side without knowing exactly what each person's going through. But let's talk about what we do together, which is the tongue tie side of things. Now, I'm going to throw a few questions at you, and I just want you to answer with just a couple of words. But do you think tongue ties are underdiagnosed or overdiagnosed?
You can't give me that question and say those are two words. I would say that tongue ties are underdiagnosed, but too quickly treated by most people. Not you, not me, but by most
Okay.
people, too quickly treated. In terms of treatment, what I mean is the release itself as opposed to the
Mhm.
process, right?
Yeah.
I will say I did the math quite some time ago, but I think it still holds. If we're going to say that babies, 4 to 10% of babies are tied, that's the number that you see in all the literature. Many numbers show us higher, but let's use 4%,
Mhm.
4% as our baseline minimum. We're not releasing 4% of the babies born.
Yeah.
So underdiagnosed.
And I agree with you as well. I think you are right that some people do rush for the treatment as well. And sorry, that some people do rush for the treatment. That can be circumstance driven, like pain is on one side and here what we do have is waiting list to see a good professional. These mothers sometimes get out of the hospital, the health visit doesn't come for another 2 weeks, they're struggling with pain, it's their first child, and they're told that the hospital there's a tongue tie, they go and they get it snipped there at a few days old. That's one of the things that I contend with as well. But to be honest, those cases are far few. Most of the time I'm getting these patients saying, oh, there's no tongue tie, or it's not significant enough. Now, how important is, in your mind, obviously, this question might sound very silly, but how important is an IBCLC or lactation support to the whole to treating a tongue tie?
So I want to say there's not IBCLC or lactation support, there's IBCLC. So I want to say that because no one else has the level of training that we do. I will say that within our level of training, you can become an IBCLC with not a whole lot of skill. You want people who are IBCLCs as baseline and then who have advanced training in working with oral dysfunction. That is critical. Because remember, I talked about how I would do a functional assessment and what all that assessment, most people don't know how to do that. That's an IBCLC skill, to make that functional assessment, to look for those nuanced compensations. And then our job is to identify them for sure, right? These are the compensations we're seeing, do an oral assessment, see where we see the restrictions and limitations orally. But then our job is to sort of guide the process. What do we do now? So what I typically will do at that point is I will do as many little nudgy things as I can to get the mother out of pain, if pain is the starting point, right? So we move back to reflexive feeding, which is part of our skill set. How do we feed that baby reflexively? How do we build those reflexes back in? So that's the first thing. How do we do that? We can usually get a mother out of pain before they ever have the release. Okay, that's really important. It doesn't mean we've gained function, but we've at least gained time, right? Because now the mother's not in pain. So what we want to do is we want to introduce oral exercises that help to repattern the way the baby's brain knows to use those muscles. So sure, the baby's not going to have full elevation of their tongue, for example, without a tongue tie release. But we at least want the brain to make that connection to go, oh, wait, it's possible to move that tongue in this way. So we start to do oral exercises that are customized to the baby, not YouTube videos, customized to that baby, to start to repattern the way that baby is dysfunctional, right? We change the positioning at the breast so that the baby has to be in extension to feed, to engage the mid blade of the tongue, because that's what we want. We send the baby for body work. 99.9% of my clients get body work everywhere in the world. We send the baby for body work, and usually with a little baby, 1 to 2 sessions. That's what we need before a release, not weeks and weeks, not 3 times a week for months, none of that. A good body worker, a couple of good sessions, along with the oral exercises, along with the movement interventions that we use. And then we refer for, once the body worker and I are together on this, we refer the baby for release. I am very picky about release providers, as you know. And so I educate my families, and education is a critical part of our skill set. I educate my families to understand why those oral restrictions are causing what they're seeing. How do we connect what you're experiencing to what's happening inside the baby's body, right? And then by giving them those oral exercises and those movements to do at home, we really empower the family to start to really know their own baby. They're noticing as they do these things on a daily basis what improves, what doesn't improve, how the baby responds. And so now they are the primary movers in terms of getting that baby to function. It's them. And then once we do, so I do what I call my elevator talk. Actually, it's what my interns called it, before the release, where I explain the whole process, how the dentist is going to, manage the release, what they need to do in the first 24 hours. I teach them about the meltdown period, which all the babies have. And I explain how that meltdown is not pain, how that meltdown is a mobility issue, that the baby has gained function of the tongue to a degree. We have this tongue that couldn't move before, it could only do this, now it can do this. And so it does like mad, and then it fatigues. And so about 6 or 7 hours after the release, that fatigued tongue goes, I'm not doing anything anymore. So the baby doesn't want to nurse because they don't understand how to nurse without moving their tongues. And then they go into what I call their meltdown period. So I talk parents through that ahead of time, how to manage that ahead of time. I talk to them about pain relief, which we recommend homeopathy, not any medications. And I talk to them about, I prepare them for the contraction phases. I talk to them about how they're going to manage that. I talk to them about what exercise we're going to do afterwards, about frequency of wound care, like all the ways we're going to get their baby to full function. And so I tell them tongue tie release is a process, not a procedure. The procedure allows the process to unfold. The procedure does not gain function.
Very well put there, because we both say the same thing. I always say the tongue tie release is only one small bit of everything. And I said, in essence, it's always the body work, like you said as well. It's the lactation support, it's the regaining of function, which takes time. Now, before we actually go on to talking about the post-team that you just mentioned, when you were talking about your exercises that you give to parents, the functional exercises, recently on social media, I've been seeing that some people advising these exercises mitigate doing a tongue tie release. And from my eyes, knowing the anatomy of a tongue tie or lip tie or any other oral restrictions, I know you might get some stretch of those tissues. Like you said, you may improve the feeding. But do you think that this is a viable way forward just for parents out there who've been promised this?
Yeah, it's actually a big problem. You're 100% right. I'm glad you brought that up. I see a lot of body workers actually claiming that body work can solve the problem too. So I think one of the advantages that I have personally is having had Betty Carrillis as my mentor. So she was the person who first ever did
Mhm.
a posterior tongue tie, right? She was a pediatric surgeon. And I will tell you the reason she did it was because she believed a mother. The mother said to her, I know my baby has a tongue tie. And
Mhm.
Betty said, I don't see it, because back then we thought tongue ties were only those anterior tip of the tongue ties, right? And
Yeah.
but Betty believed the mother, and she did the release, and that is how it all began. It was a belief in a mother. And so I was very lucky to have her, and I was very lucky that when I met her in 2005, I
Mhm.
dragged a chiropractor along with me, Dr. Sharon Vallone. I dragged Sharon into the process right from the start. And so everything we learned together. We learned to understand together how the body was working and responding. And what we realized, we sat down and we looked at the clients that we had had together, because we'd collaborated already for a decade at that point.
Mhm.
And we looked at the families where they had to keep coming back for body work, or they had to keep using a nipple shield. Like, we never got them fully there, right? And we
Yeah.
realized those families were the kids with the ties. In fact, there was a mother who I since
Mhm.
became friends with. Her daughter just started college, actually. And I never got her back to breast after her tongue tie release. And she'd had an anterior tongue tie release with an ENT, and we never got that baby back to breast. And she was about 2, and I called her and I said, "Can I come over and look at your daughter?" And I went over and I saw the posterior tie, and I
Mhm.
was devastated. I felt like I had failed that mother. I failed her.
Yeah.
That's how I felt, even though I didn't know. It just felt devastating to me that that mother was never able to breastfeed because of what I didn't know. And I decided that that was not going to happen again in my practice. And so, in bringing Dr. Vallone in, what we did is we tried all of the things that people now are claiming work. We tried, let's only do the lip release. Let's only do the tongue release. Let's just wait and not do the buckles yet. Like, we tried all of that. Like, we thought we were being as minimally invasive as we could be, right? We thought we were being conservative, and it failed over and over again. We had to go
Mhm.
back and do the things we hadn't done. Let's see if we just do body work, what will happen, right? So we actually are the failures that we wish other people would rely upon and not repeat those failures, because we did those. We did it. In fact, the very first paper ever published on posterior tongue tie by Cliff O'Callaghan, about 2/3 of those clients were my clients, and every one of
Wow.
them had had body work. Every one, with Dr. Vallone. That's not mentioned in the paper, but I believe it's one of the reasons that our successes were so high was because of that. So I think it's really important to understand where we came from here. And so what I tell parents is those are compensations too. All you're doing is introducing a different compensatory pathway. You're not introducing a functional
Mm.
pathway. And it's a legitimate choice if it's an informed choice. If a parent says, "I don't want to do it, and this is the path I want," I will guide them on that path. I will tell them the best thing they can possibly do. You're probably going to be at the chiropractor every other week. You're probably going to end up with your child needing expansion and maybe whatever later. But it's a choice a parent has a right to make, but it should be informed. And those people who are telling parents that they can do this instead, that's a lie. That is not an informed choice. So are you just keeping them in your practice now forever? Is that what you're doing? Because I don't think that's
Mm.
ethical, right? So I think a lot of these people, they don't have the history that we have. They haven't seen 20 years of this progression like we have. And I think it's really tragic that that's being done. And we all know there's a well-known osteopath who's out there claiming that the osteopaths who support tongue tie release are just bad osteopaths. Well, I can tell
Hmm.
you some of the most phenomenal osteopaths, including Dr. Michael Geis here in Connecticut, who is brilliant, recognize the importance of releasing these ties. So that it really troubles me because who wants to put their kid through a procedure? I wouldn't want
I
to.
agree.
No one wants to. And so you're feeding into people's desire to not do this, and I understand that, and their fear around doing it, and I understand that, but you're misleading them as to what the long-term consequences are. And just to make this one last statement, for me, I have had a group for my parents on Facebook for like 12 years, 13 years. I don't know however long it's been. There are families in that group whose kids are now in college. Like I've been there, they've been there forever. So actually longer than
Hmm.
that. So I've been able, and also I run a free support group for my clients on Fridays. So I've been able to follow my clients for long periods of time and see the outcomes. And I see the kids who end up needing the releases later or need to end up needing expansion later, right? I'm not saying a tongue tie release is going to prevent that because we have the perfect storm of
Hmm.
high palates, recessed jaws, and short frenna, right? We have that perfect storm. We're only fixing one when we fix the tongue tie. Sure, it impacts
Yeah.
the palate and sure it impacts the mandible, but it's not a full, complete reorganization. So I think that lactation consultants are a little bit unique in our ability to kind of see how that plays out over time compared to the dentist, for example, who typically won't see that family again unless they become their client. So I think that that's very misleading and it's very concerning to me that I'm seeing that out there so much.
It does worry me a lot because I obviously I always keep a very open mind. I wasn't I questioned tongue ties a few years ago. Now look what I do. But when I see this and I'm looking at how my impact on the families can be, and I've unfortunately seen some patients who've gone through it, it's not been very positive. But I'm always looking to find the truth. If there is a way, I'll be honest with you, as a tongue tie release provider, I don't want to cut a baby's tongue if I don't need to.
Agreed. Agreed. It is the worst
Uh,
thing that has happened in the field of lactation, to be honest with you. It is the worst thing that has happened.
mm,
Tongue ties have become highly monetized. So no
mhm.
one cared about lactation before there were tongue ties. Now everybody's an expert. I always say that if what you know about breastfeeding is what you know about tongue tie, you know very little about breastfeeding. But so many people out there now, SLPs, OTs, dentists, chiropractors, think they're breastfeeding experts because they understand tongue tie to a pretty good degree. They do not understand breastfeeding. They understand tongue tie, and they are not the same thing. And so I agree with you. And as a parent myself, who did all the least possibly invasive things with my children, I totally get this. I have my kids at home. I raise my kids with natural medicine. I am the last person on earth to actually want to do this. I hate that we do this. But one of the things I also understand from being a myofunctional therapist and working with people all the way through their lifetimes and having my own ties released as well is that being tied is a far more challenging thing than it is to have a tongue tie release. Having your entire system limited in range of motion, having your reflexes not able to fully integrate, having your system not able to fully downregulate because you're in that pattern all the time is a far worse outcome than a 6 week post release protocol, which is kind of what I use, 5 to 6 weeks. So if you have to compare the two, so I'm with you. The day we find a way to not do this, I'm going to be right there I will be right by your side advocating that we do it that way. Trust me, I will.
Well, I say the same thing as you as well. I think comparatively, from a very clinical point of view, performing a tongue tie release on a baby, obviously, if needed, is a very simple from a surgical point of view. You use a CO2 laser, it's fairly quick, easy. Parents do exercises. 6 weeks later, they're all done. That tongue's functioning really well, provide obviously see an osteopath and body worker. And if we look at the finances at some point, because everyone looks at finances some way, shape, or form, especially in the UK, you're actually saving money by, I believe, by doing it earlier because you're not having the
Mhm.
expansion, the orthodontics, the myotherapy in the future. And we also have the other benefits, like you said, like that system is not compromised as much. It's working really well. It's not how the reflexes can integrate a lot better as well. But back on the topic of UK, now a very controversial topic here is lip ties and buckle ties. And the thing I get thrown at me a lot is there's no evidence. This has not been scientifically tested. And I come back to saying, well, I work with lactation consultants. A lot of the times, my lactation consultants are asking me to release the lip because they see it's heavily blistered. They see that lip's not flanging outwards, and these babies are showing symptoms as well. And I said, conducting a study on babies would not be very ethical. And that's why there won't be much literature on this side on lip tie alone, because you can't say to a baby, do a lip tie, we're going to do the tongue tie later, etc. Because if that baby's struggling, that family's struggling, you're not giving them the right chance to make things better. But tell me about your view on lip and buckle ties.
Yeah, as I said, we tried to not do it, right? We tried to go, oh, let's just do this, let's just do that. I always say if you have two hands tied behind your back, why are you untying only one? Right? That makes no
Hmm.
sense to me because all you're doing is developing new compensations. So when you release only one tie, you're only allowing the body to just take a new compensatory pathway. You're not giving full function, right? The lip is actually the part of the body that in infants is fires most in the brain. It's the lip, not the tongue, actually. Babies' lips are really critical to function. It's how they learn to speak, it's how they learn to eat. So the lips are super critical to function. So anywhere that lips, remember this is a ring muscle, right? Anywhere that the lips are
Hmm.
impeded in function is going to impede feeding. And so we're not talking about just the upper lip, we're talking about the lower lip and the buccals. And what I say to families is we have 7 places where we have a frenum in the mouth that is meant to manage mobility, right? We want the exact right amount of mobility. We don't want it to be too mobile. We don't want it to be too restricted, right? So when that tissue forms, it forms for a reason. It forms to keep that mobility within a healthy sort of framework, right? When it's too tight, you're limiting function. And what I find
Hmm.
is that the buckles are just and the lower lip are just as critical. Now, I used to ask dentists back in the day, why aren't we doing buckles? And they'd say it doesn't have anything to do with feeding. And then I thought to myself, you're a dentist and I'm a lactation consultant. What am I doing? Wait a minute. Like,
Yeah.
that's my domain. So back in 2014, Dr. Kotlow released the first buckle tie I had ever asked to be released because I had a family who had adopted their baby and they were feeding with a feeding tube at breast. And the baby could nurse on one side really well and move milk, but not the other side. And she had a really tight buckle on one side. So I asked Larry, I'm like, would you please release? He'd already done the lip and tongue. I said, please
Hmm.
release this buckle. He goes, and we had a great relationship. He would do anything I asked as long as it made sense to him, right? He goes, absolutely send the baby up. He did the buckle. Boom, that baby could feed on both sides, right? And so after that, I started working with Dr. Condell, who's here in Connecticut, who does adult releases hands-on with Dr. Geis. They do them together where Dr. Geis is guiding the
Hmm.
releases, the osteopath. Releases are amazing. I've attended a lot of those releases. And so when I've seen the impact of buckles on adults and my own buckles, I had my upper buckles released by Dr. Condell and he wasn't going to do them. And I said, no, Lenny, I can feel the tension. I can feel it. Like all, he goes,
Hmm.
okay. So he did it. And I remember him and my son both going, whoa, like noticing the release of tension when he did this one.
Hmm.
And so I've seen that in so many adults. I've seen adults literally start laughing out loud when their buckles are released. I have seen them literally take a breath like they've never taken before when the lower buckles are released. So when I see that happening in an adult, what reason do I have to think that a baby isn't having a similar experience? But what I have found is that when I have a babies released where a dentist won't do either any buckles or won't do lower, like what weirdness is that? You'll only do the upper, not the lower. Then we do the release afterwards with a different dentist. The release, the outcome is night and day. I've just seen it
Hmm.
so many times in the last, what's it, 2014, right? 12 years that there's no denying my clinical experience. And I will say this, we were releasing tongue ties before there was any evidence. We were releasing lip ties in the United States before there was evidence. So the argument that there's no evidence is such a strange one to me because all those people who are out there cutting tongue ties were doing it before there was evidence, right? They were doing
Hmm.
it based on clinical observation and experience, which, by the way, are the 2 other tiers of evidence, right? So the idea that evidence is only an RCT is ridiculous, right? Our clinical experience is critical. So I just feel like this is something we need to talk a lot more about because I tell parents that often the buckles are more impactful than the tongue in terms of releasing for function. They actually are, because often that mandible does not come forward just by releasing the tongue. It's releasing the buccals that tends to have that outcome. So I think they're critically important, and I don't refer to anyone who won't do them. I have clients willing to travel, as you
Mhm.
know, to you, um, who are willing to travel once I educate them as to how critical those are as well, right? And the more dentists are willing to do them, the more they become a common expectation that they can and will be done.
Yes, it's I think the lacking thing we have here is the guidelines don't actually mention too much about lip tie, and there's we our guidelines are already 35 years out of date anyway. And when you talk about using a pair of scissors to release a lip tie, that's not something I'd ever wish for a baby. And there's, as you know, laser providers, not many of us around who can actually do them. So that's where we also fall into a smaller category, because as the predominant releases here are done with scissors, you won't use, it's not ever ethical, and I wouldn't ever advise anyone to get a pair of scissors and use it on a lip tie due to the risk of bleeding. And that's where we're very lucky to have some lasers as well. But another point I wanted to talk to you about as well is the post-operative healing, which you and I, which I'm very grateful, number one, for you to ever introduce me to serapeptase, because that really did change how my wounds healed post-surgery. Because we all talk about the surgery as the one big part. And as I said, and I always say, this is quite insignificant, because you could more or less do a surgery really well, but if they don't do the exercises or if they don't have the right support, etc., you've basically done that procedure almost for nothing. Yes, okay,
Right.
you might get some, if it's an anterior tie, yes, you might get that whole front blade moving, but if it's a posterior, the likelihood of regrowth,
Right.
etc., is quite hard. So talk me through what you would say your most perfect post-op aftercare would look like for parents.
And that presumes that really nice release, right? So when we
Yeah.
have a really nice complete release, like a really nice diamond under the tongue, when the
Mhm.
lip is clean and fully released, if that's there, the lower lip if it's there, and any buckles. So we have nice potential for mobility, right? Then what I tell parents is the wound care is really critical. And what I learned about 8 years ago, and I learned so much from my clients.
Mhm.
Watch your clients, watch because they figure things out, right? Because they're so good at
Definitely.
responding to their babies. So what I learned was that if we do our wound care before every daytime feeding, we create the possibility of like a physical therapy for breastfeeding. So if the baby's tongue is kind of hanging out on the floor of the mouth in between feedings, right? And then we go to feed the baby, they're going to do this. But if we go in there and we do our elevation, I call it an elevation because I don't like the word stretch. If we do our
Mhm.
elevation before the nursing, we've engaged this mid blade of the tongue, and now we're going to have that happening, right, during the feeding. It's the mid blade that matters. That's the part of the tongue we want to learn to move properly. So I've learned that if we do that wound care before every daytime feeding, not a snack, like 2 to 3 hours, daytime feedings, and no longer than 4 hours at night, a couple things happen. We have a far better outcome for the release, and it's far less painful for the baby. Because what I tell parents is you want to keep the wound open, not tear it open. If you do it 3 times a day, 4 times a day, you're going to tear it open every single time. But if you keep it open, it's really not uncomfortable for the baby. The baby doesn't want your hands in their mouth. They're like, get out of my face,
Mhm.
but you're not hurting them, right? But I also found the contraction phases were such a huge challenge for parents. So I educate my families ahead of time. Contraction is normal. Wounds contract when they heal, all wounds. And you
Precisely.
can you can kind of feel that yourself. You get a cut, you get a scab. The scab feels kind of tight, right?
Mhm.
So I say that's what happens in a baby's mouth. It starts to feel tight. And as it feels tight, the baby's like, oh, my space is smaller. Get out of my face, right? So I tell them I used to say we just have to get through it. We just have to kind of get through that period. But I did have two dentists intervene in my life.
Mhm.
Gary Myers in Florida was doing some Kenalog injections into babies who only had a history of scarring in the family, like really significant scarring.
Mhm.
But he's like, I can't do this like as a routine. That's not a good thing. And Kenalog has danger for babies. So I talked to Dr. Condell about it, and he said, well, can't you figure that out? He's like, figure something out. He's like, he did. This is Lenny. I love him. He
Yeah.
said, figure out an enzyme. And I went, wait a minute. Okay. For years, my mother-in-law had a blood condition where she made too many platelets and it put her at high risk of a stroke, right? And
Mhm.
so, like 30 years ago, I went and did research, and I will say I put her on, her doctor was well aware of it, but I put her on proteolytic enzymes, which kept her really healthy. She lived into her 90s, right? So I had her start taking proteolytic enzymes, and they made a world of difference. So I thought, wait a minute, I know this. So I just went and started researching the proteolytic enzymes,
Hmm.
nattokinase, serrapeptase, and I thought, okay, this is such a simple solution. We can just take this enzyme, take it out of the capsule. As you know, it's enterically coated, so its systemic effect requires that it be swallowed whole in the capsule. So if I take it out
Hmm.
of the capsule, it doesn't have a systemic effect, but it can have effect right there on that tightening tissue. Because what that
Hmm.
tightening tissue is that fibrin, right? And it digests fibrin. That's what proteolytic enzymes do. They digest fibrin. They digest dead tissue. That's how a moth gets out of a cocoon, right? It sort of digests it. So I about 8 years ago, almost nine now, I guess, I started with babies who were reattaching. I started with them
Hmm.
because I'm like, well, a reattachment is like nobody wants to do this for a third time. This is like, we've hit the wall. So those are the babies I started with, and all the adults and children. And adults could say to me, oh my God, as soon as I put that in my mouth, it was so easy to do my elevation. I could just feel it so much easier. And the parents would say that the babies, it was a struggle. It was a struggle. Wow, I could just lift the tongue. So I started recommending serrapeptase for the babies at that during the contraction phase. And I'm like, just do it 2 times a day. You're going to do your wound care,
Hmm.
what, like 8 times a day? Just do the serrapeptase twice a day during that contraction phase. And then in our second contraction phase, which is usually around 10 days to 2 weeks, we'll reintroduce it. But you also are now in there feeling it all the time. So if
Yeah.
you, oh my gosh, I didn't get up in the night, I didn't do it first thing in the morning and use your serrapeptase. It
Hmm.
creates a sort of forgiving environment. It doesn't mean we want to use it instead of, but it does give us more wiggle room, right, to be imperfect as we are as humans. So I just found that the outcomes were night and day. And my parents, especially the parents I had worked with before serrapeptase and after serrapeptase, they're like, wow, this is like a game changer. And it really has been a game changer. So that and we use homeopathy also. We use homeopathy instead of anything else just for wound healing. I tend to use calendula also because calendula helps wounds to heal without scarring. So we use it in a couple different ways, either as a hydrosol or as a tincture, kind of mixed with like aloe and just kind of drop it on the tongue. So we do some other things to support healing. The older babies, we use the serrapeptase longer. We might do like a 8 week protocol instead of 5 weeks. Or parents will often do it once a day with the older babies because the older babies are hard to deal with in all the other ways.
Hmm.
But all of that is done parallel to changing our exercises throughout that process. Like we're doing oral exercises, we're doing movement, we're doing body work, but as the baby gains certain function and they no longer need a certain exercise, but now they're not maybe holding their extension or maybe whatever else they need, we'll move our exercises to the next step so that we gain full function. So I think being a myofunctional therapist really did help me to kind of step
Hmm.
back, and kind of see how I could take that material and introduce it into the baby world, which is how we created the IBCLC masterclass in 2017. I kind of took all that material and we kind of poured it into that 32-hour course for lactation consultants. So, so yes, the I tell parents that what you do afterwards is critically important, and our focus is always engagement of the midblade of the tongue. It's not the healing
Yeah.
of, because wounds will heal. Your wound's going to heal. Engagement of the midblade of the tongue is our goal, right? Losing our compensations is our goal. So the other thing I do want to say is that we also have to address the parallel issues of like reflux, milk supply. Moms might be back to work. They might need their flange sizing. Like there's a lot of other breastfeeding stuff that needs to be done in parallel too, right? So there's a hyper focus on babies' mouths right now because all the OTs and the PTs and the
Hmm.
SLPs, everybody think, oh, I'm the expert on baby mouths, right? But that's not how breastfeeding happens. Breastfeeding is human to human, right? It's not a mouth on a breast. And so it's really important that we not hyper focus on that and we maintain that ecosystem of the dyad as the place we're supporting through that process.
No, thank you. It's honestly so refreshing to hear about your serapeptase protocols. And like you said as well, I find it has the exact same thing. It's a very good kind of insurance policy. I said it to parents. I said, you know you're going to do the stretches. Okay, you might not get too well, etc. But also the fact we have to deal with a healing wound, which the mouth heals very fast. And
Hmm.
the tongue, unfortunately, is one of those areas you do a great release, but actually you can see that top of the diamond sitting down. If most parents in the UK are told tongue tie elevations or stretches, there's no, once again, we talk about evidence base again, there's no need to do it. And then unfortunately, these babies are being divided 2 or 3 times post frenectomy. And I'm there like, no, we want to, if we want to do this procedure, we do it once, we want to get it right. But we, that's where we have in our clinic, we see our patients about 4 times, because one at 1 week, one at about 3 weeks, one at 6 weeks. And if they want to come in more, we encourage that, because the more and more we can support our parents coming through, especially at this point, it's always good. So we're going to do a few rapid fire questions for you. Now, one myth about breastfeeding you wish would disappear.
Um, that babies shouldn't nurse to sleep. That's one, because that takes the relationship out of breastfeeding, right? The idea that somehow breast milk is
Mhm,
just food as opposed to a relationship. So I guess any myth that kind of separates
mhm.
the mother and the baby is what I would like to disappear. And I have to say this, the fed is best has to
Mm.
disappear. That has to
Yeah.
disappear. It's such a reactionary concept, and it's not, it has no legitimacy. The idea that the bare minimum is best is absurd, right? It's the bare minimum to
Mhm.
feed a baby. We all have to feed our babies. So I wish that things would disappear that are meant to attack breastfeeding, because it doesn't support anyone. It's just an attack.
Yeah, I agree with you. And one feeding behavior that parents worry about that is actually normal.
Oh, well, nursing to sleep is actually normal. Um, yeah, I mean, I think that all feeding behaviors that involve the need for contact, the need for comfort, whether it's napping on the mom, whether it's nursing to sleep, whether it's co-sleeping, all of the behaviors that say, I just need to be close to you, right?
Mhm.
That's normal. And I wish parents wouldn't worry about that.
Now, one important thing parents should know about tongue ties.
Uh, let's see. Well, I think one important thing is that it is, I believe, a perfect epigenetic storm that we're seeing, right?
Mhm.
I don't believe it's that we're just better at finding them at all. I think that we're actually seeing a transition in human evolution, not evolution really, because it's too short of a time in our epigenetic presentation or pressures. And we have this perfect storm of high palates, receded jaws, and short and tight fronta. And I wish that parents would understand that that is really the sort of process that we're dealing with, right? It's not just the tongue tie itself, which is why the process is so important, right? Because what we're trying to do is we're trying to influence all of those in a positive way, right? Not just cut a tongue tie.
Mhm. No, exactly. And one thing every healthcare professional should understand about breastfeeding.
Oh, well, if a mother tells you breastfeeding is important to her, believe her, because so many
Mhm.
healthcare professionals diminish breastfeeding, right? They tell the mother it's no big deal, it's not important. And I would say this too, maternal anxiety is not a mother problem, it's a culture problem. Because
Mhm.
you mentioned this before, mothers know when something is wrong. They know intuitively when something is wrong. And yet they're constantly
Mhm.
told, you're wrong, you're wrong, you're wrong, or there's something wrong with you, right? So that
Yeah.
when a mother goes to multiple people for help, she's treated as if somehow she has a problem, right? Look at her, she's seeking help from all these people. So what I tell my clients is that being anxious in the face of being ignored is a normal response. Being anxious in the face of knowing something is off with your child and everyone dismisses you is a normal response. There's nothing wrong
Mhm.
with you. The problem is no one's listening to you. So listen to mothers and respond accordingly. And if you don't have the skills to respond, then send them to someone who does. But do not dismiss mothers because that is unacceptable.
Strong and beautiful words, and something that resonates with me very strongly. And unfortunately, I see that a lot. Now, just before we close, I'm going to ask one more question to you. Recently, there's been some trends of people who, let's say, do tongue tie releases, training in body work, and training in lactation as well, or becoming an IBCLC. Do you feel that this makes the process very like prone to bias? Because how I kept it in such a way is I will only focus on the release. If I was then looking at the lactation at the same time, then I'm expecting everything to get better because of the release. Whereas I have someone to answer to. For example, Heidi, who we both know is a good friend of ours, I have the body worker to answer to
Mhm.
kind of on that side. And I also have them to kind of say, oh, well, this is what's going on. How do you feel about this as well?
What a question to end with. um, so actually, it's a really important question, though, because one of the things that I'm seeing is a lot of overstepping, right? So I told you I'm also a myofunctional therapist. So you could say, well, you've kind of tracked into multiple places, right? But I was an IBCLC for decades before I
Mhm,
became a myofunctional therapist. And the reason I became a myofunctional therapist is because I did a talk for Barry Rayfield when he was doing his podcast back in 2012, just introducing the whole airway thing, right? And I was
mhm,
a guest on there, the first person to talk about tongue tie. Joy Muller heard me speak and called me and said, I want you to become a myofunctional therapist because Christian Guilleminault is telling me we need to help the babies, and I want you to be that person. So I was invited into that world, and it made a lot of sense, right? It made a lot of sense for me because it
mhm.
helped me then to take that. But what I had to do was practice. I had to practice to really deeply understand it, right? And I practice
Yeah.
myofunctional therapy, I think, very differently from a lot of other people. I use reflex integration, I mean, a lot of other things, right? But it helped me a lot. I also am a body worker. I'm a licensed massage therapist. But again, years after, I also have a master's in holistic health coaching. So what I've done is I've added tools that have made me a better IBCLC. I still refer for body work. Remember, my practice is
Mhm,
90% global. So I'm not touching most of my clients, right?
mhm,
So I've added skills that have made me a better IBCLC. My argument is we should master our own profession, right? So everything I've done is to master my own profession as an IBCLC. I refer for body work. I refer for obviously for releases. Um, so I'm not doing all of that, right? I understand the sort of draw, but what I said before is if what you know about breastfeeding is what you know about tongue tie, you know very little about breastfeeding. And I call those people tack on IBCLCs because what they're doing is I'm going to be really, really transparent about this. The IBLCE has a process by which healthcare providers can become lactation consultants in a very unethical way. I'm sure it wasn't designed that way. I'm sure the thinking was that people would do it the right way. But the process allows for someone like you, who sees babies literally all the time, to just go basically take a 90-hour course and take a test and say you're an IBCLC. You don't
mhm,
need to have the capacity to help someone build their milk supply, to understand how to help somebody size their flanges for their pump, to help them return to work, to help them with weaning, introduce solids. You can literally become an IBCLC without any of that knowledge, as long as you can pass a test. And anybody can prepare to pass a test. So what we have are a lot of dentists, SLPs, OTs, PTs, chiropractors tacking on their IBCLC credential and looking like they kind of are a one size fits all person. But a lactation intake appointment is 2 hours. I want to know which of those folks are spending that 2 hours in addition to
mhm,
releasing a tie, adjusting a baby. Where are they doing that, right? And then our follow-up appointments are an hour. Is that being done? Are all of those pieces
mhm,
being tended to? No. So people need to stop overstepping. Dentists are doing too much teaching about breastfeeding. They're telling parents which bottles to use. They're telling parents which nipples to use. They're telling parents which
mhm,
exercises to do. That's not appropriate. It's just not. So I think you know how I feel about this. We should be mastering our own profession. That's what you do. That's what the dentists I work with here do. That's what I do. That's what the chiropractors I co-teach with do, right? They're really, so we're working very collaboratively. We literally sit in a room, especially the chiropractor, and with a family together and solve problems together. It's made us both so much better at what we do, but it hasn't made us the other person, right?
yeah.
So I think people need to stop doing that because I don't think that it's serving the community well at all. And it makes it very difficult for parents to know what kind of care they're getting because they think that they're getting that one size. Oh, I have a dentist who's also an IBCLC, or I have a chiropractor. But I'm going to say this in the reverse too, because I say this to my profession all the time. Lactation consultants, they're not trying to become dentists, don't worry. But lactation consultants are often trying to become body workers in a very, what I consider, unethical way too. They're going and taking a weekend course in cranial sacral therapy and going, I'm a body worker, or cranial sacral fascial therapy, I'm a body worker now. I went to massage school. I did the whole process of becoming
Mhm.
licensed because to me, that's what's ethical, right? So I think it works in both directions. Lactation consultants shouldn't do it any more than anyone else should, right? If we're going to be
Yeah.
multi-professional, we should do it the right way. And if someone genuinely wants to become an IBCLC too, then I mean, my two past interns were SLPs, but they did the whole 500-hour internship with me. They did it the right way. If you're going to do it the right way and practice the right way, then absolutely welcome. Absolutely. Yeah, but if you're going to do it just to market or to be that one size fits all, you're not serving that family well, in my opinion.
I agree with you as well, because I do find obviously it's good to get an understanding. Like, I've been on an acupuncture course. I don't actively perform it on my patients, but I went to go on it to understand about how the fascial chains are linked, etc. Now, firstly, well, now, lastly, Jennifer, I want to thank you for your time on the podcast, and just tell us, where can parents find you, or if practitioners want to attend any of your courses, could you just tell us on that side where we can find you?
Yeah, so almost all our courses are specifically for IBCLCs. However, I am working on a course for dentists about the IBCLC dentist connect, working
Mhm.
collaboratively. But most of my courses are for IBCLCs, and it's ibclcmasterclass.com. That is the website for the lectures. Um, Almost everything is on demand, although I do a lot of intensives in person,
Mhm.
and I've been doing them with dentists, which has been really awesome. I've been going into the dentist's office and we've been co-teaching together. Um, so I'm open to doing that with dentists. In terms of parents, then they can email me at jennifertao@holisticibclc.com. That's how I do have a site, but that's the easiest way is to just email me there. And if people wanted to email me professionally, they can email holisticibclc@gmail.com.
Well, thank you very much for your time and your expertise, and honestly, keep doing the good work you're doing. It was such a pleasure to have speak to you.
Well, I would say the same for you as well. I really appreciate watching you grow and be open and just being willing to have these conversations. It's really been such a pleasure. I really have enjoyed it so much.
Thank you again.